This presentation was recorded at the 2015 ANZICS ACCCN Annual Scientific Meeting.
Thank you very much, Colin. Friends and colleagues, this is the last talk before afternoon tea, and I want to emphasise that it's a reason for you to celebrate this evening because you've created this. A lot of people in this room have helped. So I'm going to press forward and again. And we're there. That's fantastic. So, ladies and gentlemen, erythropoietin in traumatic brain injury. You can see at the bottom of the slide the numbers of people, who are the kinds of organisations that contributed to it, and many of you are in the organisation's room here. And we want you to realise that what you've done is attract an editorial in Lancet. That's it at the top of the page, and that's the manuscript. Now these are proofs. They're not actually in print in final version yet. They've been there since the 7th of October. But you can go and read your good work there beyond what we talk about in the next 20 minutes. And it's great to see an editorial on this trial. These are the people that have contributed. Vast numbers of us, a huge amount of work over many years, as you can see, and a great endorsement of the collegiate hard work that's gone into this trial. It's been funded by the usual bodies, and we thank them greatly for giving us millions of dollars to do this work. And we're particularly proud of the international collaborations that have occurred here. Funders didn't write the project, and unfortunately none of us are getting business class airfares to any exotic locations as a result. Just thought I'd give you some context just to remind you all. Many of you know this area very well, but for the last 30 years randomised trials have been really trying to crack the extremely difficult problem of traumatic brain injury and what therapies to give patients with severe head injury. There's at least 100 randomised studies. There's at least 55 pharmacological studies, and majority of them have had not much success, or indeed a suggestion of harm. Definitely useful. If you've had a traumatic brain injury, we can say nothing much pharmacological at this stage. Definitely useful pre-hospital is to be intubated, and that's results that have come out of Steve Bernard's group. So that's good news. Intubation in the field is helpful. And controversial, as you know, decompressive craniectomies, therapeutic hypothermias, and other osmotic therapies. And this is a list of all the things that have been tried. I have no idea what Wilsonii injector is at the bottom of the first column. It's some kind of plant. I couldn't find anything even on Google as to what that was, but it was a Chinese study, so I guess it was some kind of herb. And right in the middle of that, the pharmacological group, as you can see, progesterone, 2 big studies recently in the New England Journal, both showing great promise until the large randomised studies showed no clinical benefit. And then a list of other things that have been tried. So the area is desperate for something to work. And so we need to go back 100 years for erythropoietin. And this is a book that describes the discovery of erythropoietin. It's actually an autobiography of the scientist who spent 30 years to try and purify it, Eugene GOSE. So a French observation in 1906 in anemic rabbits, taking plasma from them and injecting it to other rabbits, showed that red cells were produced. There was a reticulocytosis. 1977, we've got EPO finally purified, and then 1985, 30 years ago, we've been able to have pharmacological use of erythropoietin in humans. And there's a couple of studies that we need to review because these are the ones that triggered the design and the funding and ultimately the conduct of EPO in traumatic brain injury. We'll call them EPO 2 and EPO 3. Both are from Corwin's group in the United States, and both of them were not directly after traumatic brain injury, but they provided observations that supported the EPO-TBI concept. So EPO2 was a study that Corwin was interested in terms of recombinant human erythropoietin in critically ill patients, but was interested in preventing transfusion in these patients. It was to stop them needing blood transfusions and to boost their hemoglobin. And an observation in a sub-study, an observation in a subgroup, was that there appeared to be an absolute risk reduction of considerable interest in terms of patients with trauma. Now, that was not the primary target of EPO2 with Corwin. They went off and did EPO3, a much larger study attempting to confirm that erythropoietin in critically ill patients was indicated to prevent transfusion. And an EPO3 published in the New England Journal showing that they couldn't see that signal the second time they did the larger study. But again, retrospectively and in subgroup and in hypothesis-generating analyses, including a combination of that data by Napolitano, listed at the bottom of this slide, all suggested that in trauma, and many of those patients had brain trauma, erythropoietin was helpful and mortality was reduced in this group of critically ill patients. Now, EPO3 also demonstrated that there may be an increase. They observed an increased incidence of deep venous thrombosis with this pleiotropic cytokine, and so there is a possible toxicity, at least that as a toxicity with the use of erythropoietin. And so with that in mind, one can see that it is a little tricky to go off and just give EPO to brain-injured critically ill patients. Nevertheless, EPO was very tantalising. This is a picture of brain, and it is there to remind us that erythropoietin, although it increases the number of red cells, has a lot of other actions. It is important to note that EPO and the EPO receptor are in the brain. The brain is able to get a signal from EPO if EPO will get into the brain, and indeed recombinant human erythropoietin is proven to cross the blood-brain barrier. So we know that this cytokine that we have named erythropoietin has many actions. There are many receptors for it in all sorts of organs in the body, and the brain has receptors, and human EPO can get into the brain. And all sorts of models of non-penetrating traumatic brain injury or other injury, hypoxia, ischemia, prematurity, they've all been postulated as potentially responding to erythropoietin, and many animal models have been published, often with rats, showing impressive improvement in traumatic brain injury and other kinds of brain injury with the application of erythropoietin. So, using the molecule, off we went and did the EPO-TBI study. To get into the study, you had to have a non-penetrating traumatic brain injury, be not too old, over 65, and we stratified on the severity of the illness, moderate, which is a Glasgow Coma score from 9 to 12, GCS 15 being normal, so a little decreased GCS, moderate brain injury, or severe brain injury with a GCS less than 9. We wanted to treat early, so less than 24 hours since the trauma. One wanted to have someone who was not just drunk, and therefore an anticipated length of stay of more than 48 hours, a severe or moderate brain injury. We felt from a safety point of view not to have them polycythemic. We didn't want to have that as a confounding outcome, so we wanted the hemoglobin concentrations not to be elevated, and we needed consent. We used Corwin's doses, 40,000 units of erythropoietin alpha or saline placebo injected subcutaneously. The first dose was within 24 hours of injury because it made sense that early treatment was what was to be tested. We used Corwin's schedule, which is a dose weekly for up to 3 weeks. And that was only if the patient remained in intensive care. If they got better and left intensive care, they did not get a second or third dose if they were not there. we needed to make sure they didn't become polycythemic during the treatment course, and so there were withholding criteria for EPO if the hemoglobin became too high, and if thrombotic complications were diagnosed, the patient did not get further doses of EPO. And this study was very, very careful to monitor directly, as a first time, directly for those thrombotic complications. The primary outcome was based on a midpoint dichotomization of an 8-level score that you've seen once or twice in this session, but also around many times. It's the 8-level extended Glasgow outcome score. If you have a head injury, you want to be in category 8, because that is the upper good recovery. You do not wish to be in category 1, which is dead, or 2, which is persistent vegetative state. You don't really want to be even in 3 or 4. So unfavourable groups dead, vegetative and severe disabilities. Those of you who've read about the Glasgow outcome score will know that the GOS is a 5-level score, and what's happened is the top 3 levels of the GOS have been divided into 2, thus making an upper and a lower on severe, moderate and good outcomes, and thus we have an 8-level score, the extended Glasgow outcome score. So dividing in 2 in the middle, favourable, unfavourable, and we had some other outcomes. So the clarity of the outcome may be improved if we analysed all 8 levels of outcome rather than just 2. So the proportional odds model was developed to take into consideration all 8 levels of outcome. It is a statistical variant of a logistic regression model. It of course has an assumptions of proportionality to allow it to evaluate all 8 levels in the one analysis. We looked at mortality, we looked at DVTs, and also composite thrombotic strokes as well, pulmonary embolus and arterial thrombosis, looking for toxicity from EPO because we'd been warned by Corwin's and others' data. It was felt that 606 patients would be good enough for us. It was an intention to treat analysis. The only people who didn't get into that were the people who had been randomised without meeting entry criteria and who also did not get a dose of the study drug, and we had none of those, so this is absolutely intention to treat. We had 90% power to find a fairly big difference. We had 80% power to find a smaller difference in the direction of benefit if EPO worked. We had pre-specified subgroups, and the intracranial mass lesions were diagnosed on the basis of the baseline CT scan, which all patients were required to have, and that's on the basis of a dichotomization of the CT Marshall score, which is a 6-level score. We divided that into you either had intracranial mass lesions or you had a diffuse brain injury. We looked at severity as a pre-specified subgroup analysis, and as I said, the randomisation was stratified by site and severity. There were a number of sensitivity analyses pre-specified, and they include that the severity of illness of the patient in terms of their impact score, which is a composite score like Apache, but for traumatic brain injury, that we would adjust their outcome according to their probability of a poor outcome on that composite score, and that's the impact adjustment. This is how it worked. It is in principle simple, but as you all know, 600 people in a randomised study in multiple sites over 5 years clearly indicates that it was a very complex undertaking. But one could be in intensive care for up to 3 weeks. One could get up to 3 doses of EPO, 40,000 units each, separated by a week. And if you were unfortunate enough to have a traumatic brain injury that kept you in ICU for 3 weeks, you would have up to 7 ultrasounds looking for DVTs in your lower limbs to make sure that it was safe to continue and dose you again later on. And if an ultrasound shows a new DVT, then that was one of the withholding criteria. So this is the first big study to spend a lot of money, and these are expensive things to do, but to spend a lot of money to confirm actively, scientifically, that it was safe to proceed rather than just wait for a clinically diagnosed problem, which, as you know, is pretty much hit and miss guesswork. The patient flow, well, we had over 98% of patients followed up for 6 months, and you can imagine in an international traumatic brain injury study that that is a magnificent achievement, and it's thanks to everyone in this room that that was able to be done, and thus one can have confidence in the outcomes. The baseline characteristics are true to what we know about traumatic brain injury. It is predominantly a young male disease. As you can see, young males are stupid, they drink alcohol, take drugs, drive fast, but the good news is that there are quotes from Homer, I believe, from 2,000 years ago, complaining about young men driving their chariots too quickly through Rome. It's the same, you know, they're stupid. But that's what testosterone does. And you'll see more of that tomorrow, I believe. No, the day after. Lots of testosterone on display. And possibly, we hope, no traumatic brain injuries. But if there are, you'll be able to decide soon whether they need EPO, because we're coming up to the results. These are the causes of the injuries in our community. You remember they're non-penetrating, so we're not interested in gunshots or other things. Fortunately, none of that in our two communities very much. It's motor vehicles, falls and jumps and skylarking and things like that, bicycles, motorcycles, the things that young men play with. Severe traumatic brain injury was what most of our patients had, so you know this is serious stuff. They have a very, very high risk of life-changing outcomes if they survive, and so it is very reasonable that we attempt some kind of treatment in this group. And you see 3/4 of the patients were severe traumatic brain injured. They were moderately unwell. As you can see, their injury severity scores suggested that in many cases they had trauma elsewhere. It wasn't necessarily just a brain trauma that they were coming into hospital with and getting to ICU with. And the impact traumatic brain injury probability of a poor outcome, you remember that's dead, vegetative or severe disability, was just under 50-50 in both groups. So bad outcome predicted severe injury in the study. What does EPO do in that group? There was no discernible effect of EPO on the primary outcome, which is the midpoint dichotomization of the 8-level outcome. So unfavourable outcome GOSE 1 to 4, favourable outcome GOSE 5 to 8. EPO had a relative risk of an unfavourable outcome of 0.99, with a plausible range evenly distributed either side of that, and no real sense that there was any signal that would give us any hope that EPO was working in that reduction of the 8-level scale. There also was a surprise in that there was no signal that it was causing thrombosis in this group where they had been actively screened by multiple ultrasound investigations performed professionally in a critical care environment. The first time that's been done, and no signal, with indeed, if anything, a relative risk estimate in the direction of EPO causing less DVTs, fewer DVTs. Obviously it's plausible there could be up to 24% more in our confidence interval, but it could be up to 39% less inside our confidence interval there. That was an interesting finding and has caused a lot of discussion. Consistent with that finding, there was also no overall signal of harm in terms of other thrombotic events, combining a DVT with pulmonary embolus, with stroke, arterial thrombosis. There was no signal, apparently, no evidence strongly of harm from EPO in the doses we were giving to patients who were critically ill, with 3/4 of them having severe traumatic brain injury and placed in beds on ventilators. This is the 8-level score, and coloured in, going from black to white, is badness to goodness. And the top series of 8 outcomes is placebo, and the bottom series of outcomes is with erythropoietin. So GOSE level 1 is black, that's dead, and then you can see 2, 3, 4, and then you can see a little vertical line just trying to bring your eye together for where the midpoint dichotomization was placed in these outcomes. And the odds ratio that I give you down at the bottom, 1.04, is tending to a slight advantage, a 4% advantage for EPO. This is an advantage. The odds ratio here is given to you as the probability of an equal or greater, an equal or better GOSE level. The odds ratio for harm, being in the lower group, would just be the inverse of that. So a tiny signal, perhaps not really. No one is going to be interested with an odds ratio of 1.04 with those confidence intervals. But I would just draw your eye, please, to the black box, which is the dead people, because we're going to talk about those shortly. So just notice the relative size of the placebo group, who are dead in black, and then having severe disability in the other groups up to GOSE 4. And then look to see that perhaps, with the eye of faith, there may have been a reduction in mortality and a shift towards GOSE 3, 4 and 5. Not perhaps higher, but maybe to 3, 4 and 5, such that overall if you reduce mortality GOSE 1 and shift to 3 and 4, the overall category dichotomy hasn't moved, but there may be something happening there, and let's explore that a little, because that was a pre-specified subgroup analysis, what happens with mortality. Well, here's the Kaplan-Meier curve, and it's a little tantalizing. Obviously it's a subgroup. There's a possibility that is above 0.05 now that we're seeing a chance difference, because this is not the primary outcome. This is one of pre-specified secondary outcomes, but there is still a multiplicity of testing going on the same data set of 606 patients. Nevertheless, an interesting hazard ratio in the direction of benefit of EPO in terms of mortality. And if we took the bigger of the subgroups, which again was pre-specified by their baseline CAT scan with their severe traumatic brain injury, or a quarter of them with a moderate traumatic brain injury, they had no intracranial mass. These ones are so-called diffuse brain injuries. There seemed to be in this large subgroup of traumatic brain injury patients, again, a potential signal, but in none of the other subgroups. And so, like all good trialists, having spent 5 years, we cannot possibly stop with just one p-value for the primary outcome. We have to do sensitivity analyses and enjoy ourselves immensely late at night, combining this and that. These were all pre-specified sensitivity analyses. Of course, that reduces the chance of multiplicity. It reduces the chance of false discoveries a little, because you know what we did, because we told you how many we were going to do initially. It's all in the protocol. It's all in the statistical analysis plan. But nevertheless, by adjusting for the predicted outcome of the patient with that composite traumatic brain injury score, the impact score, it actually made it even more interesting as to whether EPO might be doing something towards a mortality benefit in these severely traumatized patients. So, I'm about to stop, but we'll leave you with what we think the study has demonstrated, and it'll be interesting to see what you think. EPO did not seem to improve the proportion of patients at 6 months who have got an unfavourable neurological outcome. EPO-TBI seems to have demonstrated that erythropoietin can be administered to these patients, and that they do not seem to have an increase in proximal DVTs on objective ultrasound screening repeatedly in intensive care. And there appears to be, in our estimate, no support for a big increase or a big risk of other thrombotic events, DVTs, pulmonary emboli, arterial thrombi causing strokes. That is new information, and that's different from what the literature has told us. And EPO may decrease mortality in patients that we've studied with severe and moderate traumatic brain injury, with in the estimate of EPO-TBI, a 5% absolute risk reduction in the overall sample, an adjusted odds ratio adjusted for a multi-level prognostic variable that is tantalising but is hypothesis generating. And this means, we believe, that we've opened a Pandora's box. That while we cannot recommend for you that EPO is necessary for any of your traumatised brain-injured patients, it may be that we've stumbled across evidence that was possibly initially there in Cornwood's studies that EPO may be a tonic for general intensive care trauma patients. And thus we are going to continue with further investigations in this area, and I'm authorised to tell you that Craig has been off speaking with Corwin and his group, and also with Robertson, who did a smaller factorial study on EPO last year. And we're looking for an individual patient meta-analysis as one of the next steps to try and untangle whether in fact EPO in trauma is the tonic that it may be, or whether these are chance findings. If you have further questions, you can ask me in the next few minutes, or you can, I recommend, read the Lancet. The full manuscript is there as a corrected proof. There's lots of supplementary information, and there's a nice editorial. Thank you.
If the EPO does not push more of the severe disabilities into the 5 to 8 group, would one not accept it better they don't get out of the dead group into the severe disability group? In the early days, we were always accused by the neurosurgeons, all you guys do, you know.
Yes. Look, you're absolutely correct, and it's well picked. It'd be great if I could pull that back. How do we do that? We can do this? Here we go. Just to visually get up that graph. There it is. That's the one. So there we are. This is what we're talking about. None of us want to have a severely traumatised patient survive in some kind of persistent vegetative state. And if you have a look, or some extremely disabled state where the vast majority of patients would not thank us for it. Neither is it necessarily any benefit to the society to do that, given the costs of long-term care. If you look at this graph here, you'll see that black is dead, and you'll see that the persistent vegetative state is the smallest group. It's the next one across. And that is a phenomenon around the world. All traumatic brain injury outcomes on the 8-level GOSE are like this. And so my understanding of it, and I may be totally wrong, but my understanding is that the intensivists, the people who are looking after the patients, are well aware of this problem, and they don't allow their patients to be persistent vegetative, because you see that as a very small category there. Patients who are like that are not supported. It is absolutely legitimate to raise the question of, if this treatment only reduces mortality to increase the number of people who are unable to look after themselves, then is there any benefit? Well, it is important to keep in mind that Category 4 is defined as able to be unsupervised for 8 hours, at home up to 8 hours. So it's none of us are saying that's fabulous or good, but a number of you wouldn't leave your dog unsupervised at home for 8 hours. It would cause trouble, whereas you could leave a patient in this area, you know, at Category 4 on the GOSE. So your question is extremely valid. None of us are advocating that EPO is a treatment for traumatic brain injury. What we may have stumbled across is further evidence, because these patients didn't just have brain injury, as we see from the injury severity score. What we need to do is go and do a lot more work, find out what they're dying of, see how much other trauma they've got, do the individual patient meta-analyses of how much brain trauma was in Corwin's group, how much is in Robertson's group, and try and tease out, was there ever a brain effect? Is there a mortality effect? And is it more that it's a general trauma tonic? And we happen to have done a trial indirectly of that in this group.
Anything from the Twitterverse? No? Very quiet on that side?
No twits on the Twitterverse. That's wonderful.
Tweets, I think is the right word.
Yes, no, there could be twits tweeting. Adam Dean. Adam, I can hear you from here.
So just following on from Ron's point a little bit, but do you think it's worth trying to understand a little bit the health economic impact of this
Great
study?
question. It's in there. It's been collected. It's in the protocol. It takes a long time to analyse, and we haven't got that yet. It will be published separately. And indeed, an enormously important question is the last thing we want to be doing is doing EPO if it costs more and we have bad outcomes. But I think you'd agree that there's such a signal here that we don't want to throw out the baby with the bathwater, that we're very, very concerned that if we say that there's nothing in this study, that maybe a trauma treatment is not looked at. We think we need to go further.